wasting time. This is stressing me out because this is wasting time and this is just not how this goes. Hi guys, so my name is Elizabeth, also known as Nurse Zabe. It's the middle of Elizabeth. Here on all the social medias, and I am back today because I want to discuss with you something that I am obsessed with, and that is the new Max show, The Pitt. The Pitt chronicles a day in the emergency room. It feels real, it feels raw. The nurses are there doing stuff besides just giving everybody syphilis. And Noah Wiley doesn't hurt either. But they did do something that took me out of the moment. When they portrayed a birth in the emergency room with 2 rare but serious complications. And they did some things great. And they did some things interesting. So what I'd love to do is go through that with you guys today. We'll watch it together. I'll give you some reaction, give you some education and information. And this is to any TV exec that might be watching, which in reality is no one. If you ever need a nurse to consult for anything obstetrical that you want to put in your TV show, just call your girl up. I will do it for free. So without further ado, let's go ahead and jump into it.
Women in labor, 10 minutes out.
They get a phone call. There is somebody being brought in by EMS. They're in labor and they're 10 minutes out. Here's the thing. You know where they bring patients coming in labor? They might come in through the emergency room, but then they come right up to us. So this is kind of the first thing where I was like, are we gonna have a baby in the emergency room? Because here's the thing about emergency rooms and delivering babies. They are afraid of babies coming out of people, which fair enough. I'm afraid of a lot of the things that they do, okay? And that's why we work as a team to get these patients up to labor and delivery. Sometimes it does happen, but guess what happens then? They call us and we come down and we have our special little red backpack full of all sorts of goodies if we are needing to help babies be born in an area that is not on our unit.
Natalie Malone, 35-year-old G3P2, 39-week pregnancy and active labor after a SROM.
SROM? I've never heard anyone say SROM. So coming in, Natalie is 39 weeks and is contracting. Basically, she's term. She is a gravida 3, para 2, which means this is her 3rd pregnancy. She's had 2 deliveries. She's currently pregnant. She has had a spontaneous rupture of membranes, which I've never heard called SROM. That sounds like a mushroom, but I have heard it be called SROM, but her water's broken. She's in labor. She needs to skip the ER and come straight up to labor and delivery.
I'm fine, really. It's not my first time.
All right, let's get her into trauma 2 for a quick check, and then we'll send her up to labor and delivery.
I don't know that if she weren't actively pushing, they would check her. They would probably risk having a baby in the elevator just to not be dealing with all this.
Dr. Heather Collins.
Nice to meet you. Justin should be here any minute. He was right behind me.
Any problems with the pregnancy?
Well, 3rd time's a charm. Justin's pretty nervous, though. This is his first time.
BP's 112/72, heart rate 84. Dr. Collins, can I join?
Sure.
Okay, when did the contractions start?
Yesterday. Really? My last 2 labors are very long, so I decided to wait it out this time. But then my water broke.
She may have waited a little bit too close to the sun.
Contraction!
Don't push, just breathe. Check her, Dr. King.
Okay, good.
Oh my God.
We got this.
I see hair.
Oh my God.
Baby's hair.
Dr. King has to be one of my favorite people on this show. She's so funny. But here are like 3 things off the bat that I don't love. The patient discloses, hey, I'm having a contraction. And Dr. Collins tells Dr. King to check her. We don't check people during contraction. We certainly don't check people without their consent. Also in obstetrics, we have to be very careful with our words. There are things that we say commonly that can seem really insulting or rude to a patient. I see hair, okay, pubic hair versus baby's head hair. When somebody is ruptured and there's a lot of fluid, we call them grossly ruptured. I don't love that. Little bit makes you feel like you're yucky, and you're not. And when people have epidurals and their legs are really numb and they can't move them, we say that their legs are heavy. But I should not be commenting like that. It sounds like it could be about somebody's side. When people are giving birth, they're in a really vulnerable state, and we want to make sure that we're building them up, not bringing them down.
39 weeks, crowning after a shrum.
It sounds like, though, that this woman is crowning, and how she's acting during the contraction maybe doesn't necessarily coincide with that. She probably would be bearing down some. She probably would be trying to get up off of her back.
Hi, Mom. I'm the attending. I'm Dr. Rabinovich.
Natalie, but I'm not the mom.
What's happening? You got here just in time. We're the dads. Natalie's my best friend and surrogate. We both teach fourth grade and
She's a
even share a
surrogate.
classroom.
And this is why I don't call all my patients mama, and I use their name, because this patient does not identify as a mama because she is not the mom, right? She is a surrogate.
I've got the prenatal bag, and let me pull up the birthing playlist on my phone.
It's time. Okay, Natalie. Good chance we'll deliver on the next contraction.
Bulb suction is ready.
Right, head is out.
That's actually really interesting.
Nice.
Baby came out OT. Did you see the ear? I don't know if I'm going to be able to show all of this on YouTube. What's going to get filtered or flagged? This is actually pretty accurate, but that baby came out facing aside. Let me get my pelvis and I'll show you. So most babies when they're born are going to come out with the back of their head facing towards your pubic bone. This is called an OA position. Some babies will be born in an OP position, which means that the back of their head is facing towards your spine. But this baby actually was born in an OT position, which is going to be just a really wide diameter for the head to even come out, and makes me think that the shoulders probably are going to be coming out a little bit interesting too. Now, normally in between contractions is when your baby is going to restitute. And what that means is that they are moving from being OA or OP and shifting to be OT again, so facing one side or the other. And that is going to allow the shoulders to come underneath the pubic bone. Because while you might think, oh my gosh, the shoulders are the widest part of me, the shoulders are the widest part of a human. For a baby, the widest part of them to be born is their noggin, because their shoulders come down on two separate planes. So typically that top shoulder is going to come under the pubic bone first, and then the next shoulder will come out.
Your big one.
You said that the last 2 times.
Shoulder dystocia.
The head's pulling back. That's called the turtle sign.
This patient has delivered the baby's head. It's come out and then it's kind of gone back in. And that is known as the turtling sign, where basically what's happening is the shoulder is caught under the pubic bone. A shoulder dystocia is a rare but serious medical emergency. It is unpredictable and often unavoidable, according to ACOG, the American College of Obstetrics and Gynecology. And it occurs in 0.2 to 3% of vaginal deliveries. There are some things that have been identified as risk factors for shoulder dystocia, but keeping in mind that you might have all of these risk factors and not have a shoulder dystocia, or have absolutely no risk factors and have a shoulder dystocia. So they're not super predictive. We do know that babies who are larger have a slightly higher risk of a shoulder dystocia. So conditions that can make us grow larger babies, such as gestational diabetes, especially with poorly controlled blood sugars, can put us at risk for a shoulder dystocia. Other things that can put us at risk for a shoulder dystocia is shorter stature, having a pelvis that is maybe a slightly smaller size, multiparity, or having other children, as well as precipitous delivery. And that is because maybe baby is coming down really quickly into the pelvis, doesn't quite have time to shift into a good position for those shoulders to be born. Really long labors sometimes have more of a risk of shoulder dystocia, and pushing for a long time can as well. And that is really because those 2 deliveries might say, hey, this baby is malpositioned or a little bit bigger, or they might need an operative or assisted vaginal delivery, such as with forceps or vacuums, which definitely will put us at a higher risk for shoulder dystocia.
What's going on?
Baby shoulder might be a little stuck on your pelvic bone.
It's nothing for you to worry about. We'll just try something different on the next push. Ready? Why don't we all take a deep breath, huh? Everybody. One more time, dads too.
Dr. Robbie,
And
I
in.
love the deep breaths, but we are going to be moving quite quickly because we know with the shoulder dystocia, there is a risk to baby that they're not getting the oxygen or blood flow that they need. So we have a short period of time to get baby out safely. We like baby to be out within 5 minutes from the start of a shoulder dystocia. Most babies are out soon before that, though.
I'll have you help with the McRoberts maneuver. Of course. Hey, Natalie, we're gonna lift your knees.
Okay, they're doing
up to your
McRoberts,
chest
but
now.
she's not flat, so it's really not that helpful.
Dustin,
Knees up to
is
your
this
chest.
the worst you've ever seen?
This is not a
is
position
the
that we
most
would
I've
want
ever
to put
seen
in, but
of
it
you.
can help
You're
relieve
beautiful.
that shoulder.
Suprapubic pressure here.
We got you.
You're gonna feel me pressing on.
Okay,
your
he's doing the
bladder.
suprapubic pressure, but when a shoulder dystocia has been discovered, which happens pretty quickly after the delivery of the head and not 3 pushes out or whatever they are showing, we have a specific algorithm that we follow to relieve a shoulder dystocia. There are 3 maneuvers that we do, and after these 3 maneuvers, most shoulder dystocias are relieved without any further maneuvering. The first that they don't do ever in this whole episode is lie you totally flat. The other thing that we will do is actually called McRoberts maneuver, and we will grab your legs and pull them wide and open, and that is going to create some more room. The last and final maneuver that tends to relieve most shoulder dystocias is something called suprapubic pressure, and that is often performed by a nurse with the guidance of the delivery physician. This top shoulder is stuck, and we know that baby is facing this way. The labor and delivery nurse will push on and through your stomach, down on the shoulder, and kind of scrunch baby together to help relieve that shoulder and get it underneath the pubic bone.
2 minutes since head delivery.
Fetal heart rate looks good. Normal variability.
The fetal heart rate at this moment would not be looking good, and we really wouldn't be too concerned with it, if I'm being honest with you. Where the monitors would be on your belly to listen to baby is right where he would be doing the suprapubic pressure. We're moving those up and out of the way to quickly relieve that shoulder dystocia.
There. Keep going. We love you.
Go team Natalie. Late decel.
Okay, can you call Dr. Ingram and tell him to come down here, please, from the queue?
A late decel occurs when baby's getting less oxygen through the placenta. So I understand what they're trying to say here, but in reality, baby's heart rate probably would be down pretty low in this moment. And again, not something that we would be monitoring.
Burning from the local.
I'm not sure why he's giving local to this area, but sometimes during a shoulder dystocia, your provider might ask to cut an episiotomy. And the episiotomy does not relieve the shoulder, but it can create a little bit more room for your provider to manually go in and either do a maneuver where they try to bring down that top shoulder from the inside, or delivery of the posterior arm, or this arm that is closer to the sacrum. But I don't think they cut an episiotomy, so I don't know why he put local in.
Under the baby's head. I'm release that lower
So
arm.
releasing the posterior arm.
3 minutes since head
3 minutes since head delivery.
I'm Dr. Myers with obstetrics.
Nice to meet you.
And who's the father?
We are.
Oh, and who's the mother?
We are.
Roger that. OR is prepped and ready. Do we need to go up?
Not if I can rotate this posterior shoulder.
I'm pretty sure whoever wrote this show hates obstetricians. Because what obstetrician would come in to an emergency like this and be like, what's everyone's name? Who's the father? Like, no, you're coming in and you're saying, hey, I'm the doctor, I've got you, and then they are taking over. Dr. Robbie's hands are probably out. This is wasting time. This is stressing me out because this is wasting time and this is just not how this goes.
Yeah. Good. Hey, we got a baby boy.
Baby. This is the
I've got a
best
stubborn set of twins
moment.
upstairs. Admitted to postpartum. Congratulations, everyone.
And she just pieces out. That baby needs a little help. That baby's gonna need some extra help. Being like, okay, time to breathe. Let's do our thing.
Good job.
He's pretty quiet.
Sometimes it takes him a minute. Put the baby on a pulse ox and a heart monitor.
Again, NICU would be down here doing this. How we resuscitate babies is very different from how we resuscitate adults. We are all certified in something called NRP. Things that we do for babies, different than things that we do for adults. Norms for baby, different than norms for adults.
No, dry and stimulate vigorously. Very vigorously.
Shouldn't he be crying by now? Heart rate is 95.
Too slow.
At this point, we know that the best thing that we can do for those babies, dry, stimulate, all those things, you spend maybe 30 seconds on that, and then we are gonna move to ventilating with PPV, or positive pressure ventilation. We give these babies some help with their breathing, and often they come right around on their own. With a heart rate of 95, we would not need to do chest compressions at this moment.
Breathe, baby, breathe.
Here we go.
Sometimes babies do come around that quickly, and sometimes they need a little bit more help and assistance.
APGAR is now 10.
The APGAR being 10 at 5 minutes, I'm assuming, not super realistic. Most babies don't get a 10 at all, even babies that are born completely without any issues. And that's because a 10 APGAR means that you are pink from the top of your head to the tips of your toes, which realistically does not happen for most babies within the first few minutes of life.
There you go.
The dads are doing skin to skin. But we need a blanket over that baby or they're gonna get cold.
Whenever you're ready.
I really love that they allowed him to do some skin to skin before taking baby up to the NICU or for further evaluation. If your baby has a shoulder dystocia, they might not need to go to the NICU. But let's talk about what some complications might be for babies who have shoulder dystocia. There is a risk of injury to the brachial plexus nerve. There's also a risk of hypoxia, that baby suffers long-term consequences from not getting enough oxygen. And again, why we want babies out within the first 5 minutes of a shoulder dystocia being recognized. There's also sometimes risk that the clavicle or the humerus can be broken in efforts to help the baby be born. Maternal complications of a shoulder dystocia can be increasing in tears or lacerations, an increased risk of postpartum hemorrhage, damage to the bowel and the bladder, maybe physical damage, maybe damage to the nerves that might have issues for incontinence.
Can I put my legs down now?
As soon as your placenta's out.
Oh.
Breathe. Good. Here it comes.
The moment you're no longer pregnant, placenta's out.
What?
There's a lot of blood.
We are having a lot of blood. She's now experiencing heavy vaginal bleeding after delivery. This is known as a postpartum hemorrhage. Postpartum hemorrhage is another serious complication that can happen after your baby's born. And there are in general 4 causes of postpartum hemorrhage. So one is tone, the tone of your uterus. Once that placenta is released, that uterus needs to clamp down so that the wound that is left from the placenta does not bleed excessively. The next one is going to be trauma or lacerations. You can also have issues with tissue. So that would be like retained membrane or retained placenta. And then the last one is thrombin. Basically, something is going on and your blood is not clotting as it should be. Number 1 cause of postpartum hemorrhage is going to be uterine atony. And what's really cool is the uterus is a really smart muscle. It's responsive to touch. So by rubbing the uterus externally through the abdomen, and then also sometimes by manual massage, which is rubbing the uterus internally through the vagina that your provider might do. If there's a significant postpartum hemorrhage, we can encourage that muscle to clamp down and do what needs to be done.
Come on, spike a liter of saline.
On it.
What's going on?
This happens sometimes. You have to have the uterus clamped back down. Starting uterine massage, 40 of oxytocin in the back, 800 mics of sublingual misoprostol, and 1,000 of TXA.
So standard after your baby is born and the placenta is out is to administer Pitocin through your IV to help that uterus to contract down. Other medications that they're giving for this postpartum hemorrhage, TXA or trans-ischemic acid, that actually helps your blood to clot. It's a really powerful and amazing medication that we can use if we are worried about a postpartum hemorrhage. Cytotec is another uterotonic, typically one that we place rectally after delivery, but in this clip, they are saying to put it under the tongue. There are other uterotonics that we can give like Hemabate or Methergin, and all of these medications just help that uterus muscle to clamp down. We also have a variety of medical devices that can be used to help that uterus clamp down or apply pressure internally to that wound to stop the bleeding. Now, when you are having a significant postpartum hemorrhage, sometimes we have to activate a massive transfusion protocol because you can lose blood really, really quickly after your baby is born. And can I tell you something? You know what we do on labor and delivery and obstetrics? We actually have drills where we practice what to do in a shoulder dystocia and we practice what to do in a postpartum hemorrhage situation so that we are prepared. We have a cart for postpartum hemorrhage that has all the things that we might need. We have a postpartum hemorrhage kit of all the medications that we might need to help your body stop bleeding.
Is she gonna be okay? We're doing everything that we can.
Massive PPH on MTP and all uterotonics.
Any rupture, any inversion, any retained products.
Checked for all, none present.
This is all my fault.
Second unit's going up.
Still tacky at 130, systolic's only 84.
Let's try carboprost, 0.25 milligrams IM, and get a Bakri balloon from Central.
The Bakri balloon actually is a balloon that we inflate inside of the uterus that applies pressure to that wound to stop or staunch the bleeding.
You can talk to her. Get in there. Tell her some of your favorite memories with her. That'll help.
This can feel so freaking scary when it's you experiencing it. And for the support people, it is absolutely terrifying. I do love how Robbie comes into the situation and he not only sees the medical emergency, but he sees the people around it. That is great healthcare. Should an OB be there? Yes, but this is still this is why the show is so powerful. And also the pace at which things are moving really feels realistic to a true obstetrical emergency.
How much should we put in?
Up to 500. If that doesn't work, she'll need a hysterectomy.
Hysterectomy.
This is going to work. Come on, keep talking. More memories. It's good for her. It's good for all of us.
And the time we binged Game of Thrones 2 months before the finale because of FOMO.
Natalie. Hey, Natalie.
Did you guys hear the sound of the blood coming off of the bed? That's an audible hemorrhage. And it's terrifying.
We did it.
No more blood loss. Thanks for your help.
Thanks, Dr. Robbie.
Nice save, Dr. Rabinovic.
Thank you for being my best friend in the whole world.
We're family.
So after something like this occurs, even though everything turned out okay, the baby was great and Natalie is doing well, it's a lot and it's really heavy. And one of the most important things that we can do as your providers is actually have a debrief with you where we talk about everything that occurred and we go over what steps were taken, we answer any questions, and it's kind of the first step in you taking this big, traumatic, big event that happened and having your brain process it as a memory versus as a trauma with PTSD. Having a baby, even if things go swimmingly, smoothly, perfectly, is a big event, right? And so this is a big event that feels way more intense because it was. And we need to recognize that for our patients and sit with them while they try and process the event as it happens. I want to thank you guys for watching that episode of The Pit with me. I really encourage you to go back, watch all the episodes. There's a lot more patients and a lot more stuff going on. I hope this helped you to better understand obstetrical emergencies like shoulder dystocia and postpartum hemorrhage. And until next time, bye guys.